today, or rather the objectives, are to describe my real life experience with biologicals, specifically secokinumab. The efficacy, the ease of use, the safety, the unmet needs and the treatment hurdles we face, and to discuss what is treatment success and what's treatment failure. Of course, my disclaimer. This is a beautiful picture of Sheikh Zayed Road in Dubai, around 30 years before and what it is now. You can see the tremendous development that has taken place. Amazing the way that the place where we live in has developed. Similarly, let me tell you, within the last 30 years, psoriasis and the story of psoriasis, the history, has undergone a sea change. I don't want to go into ancient history. All that I want to start with is the T cell. We are very sure it is a T cell driven disease now, thanks to cyclosporin and the effects that cyclosporin had on the immune system and its response in psoriasis. Of course, bone marrow transplantation. Bone marrow transplantation and cyclosporin came into vogue in the late 1990s. And with bone marrow transplantation, we clearly can demonstrate that a patient who has psoriasis, if given a transplant from a patient without psoriasis, of course the psoriasis goes away and vice versa. The tremendous improvements in genomics and in the biologics of late have actually made the treatment of psoriasis reach a stage where we are going to discuss about possible cure for psoriasis. The National Psoriasis Foundation in the United States last year had declared that cure for psoriasis should be our goal. And a series of Delphi meetings have been happening where a definition of cure is being discussed. And I'll come to that later on. And this year, in fact, we'll be having a consensus. The story of HIV management and psoriasis is running pari passu. And we are at an exciting stage where we have a plethora of medications available for psoriasis, which can almost clear it. We are talking about more than 90% of patients on treatment who achieve significant improvement, and possibly even more than 50% who achieve a near clear skin. So let me go on to my next case. I want to discuss two things: my own real life experience in an office setting and the literature, and try to match both. My first case, of course, it was not the first case I started on a biologic, nor was this my first case on secokinumab per se, but I want to put this as my first case, a 45-year-old gentleman who had been having psoriasis for a long time. I had seen him for nearly 15 years. He initially came to me with genital lesions and then psoriatic plaques on the hands, feet, with a bit of arthritis both distal and axial. Initially, I had considered even the Reiter's syndrome in him, and in fact, I had sent him to CMC Vellore. Dr. Renu might remember this case. 15 years ago, he came there for a HLA screening. He was HLA-B27 positive. The thing is, his phenotype was predominantly psoriasis. He was married at that time recently. He did not have children. Of course, he underwent almost all the treatments imaginable. And I even sent him to Jordan for a bit of bath in the Dead Sea. With all the treatments, he used to achieve an improvement which was not sustainable. He used to relapse pretty frequently. When I decided to start him on secokinumab, this was nearly 4 years ago, believe me, almost a year after it hit the market. His PASI, DLQI test, and all those things are mentioned there, and his pre-evaluation for biologics was normal. And the issue I faced was with the insurance initially. The insurance was not convinced even after I demonstrated to them that even an 8 weeks course of methotrexate of the adequate dosage was not producing an improvement in this gentleman, and his PASI, DLQA and test were significant. The insurance required a second opinion, and I told the patient, look, they are the payers and they have every right to ask you for a second opinion. He did go for the second opinion under my advice because he was quite reluctant, but I told him, look, this is not anything personal. You do need this medicine, you go and see the other doctor and maybe come back to me. The second consultant concurred with my decision to put him on secokinumab, and let me say that these are pictures of before and after. let me tell you that the before and after picture was taken approximately 3 weeks into the loading dose itself. Of course, this is a picture about 6 months later, and this is how he looks now. He has been on secukinumab for nearly, let me say, 4 years, and he has been pretty compliant. Of late, the insurances had been creating problems for me because they said if he has a PASI 0, DLQI 0, how do you justify continuing this medication? This winter season, he had a minor small block in the leg. Anyway, luckily the insurance did concur and they gave him the medication. I would like to discuss what is treatment failure, what is treatment success, what is primary failure, what is secondary failure, and what are the parameters that we use to define these later on. Of course, time is of concern. My second case was, this is still the first case. The second case was a Filipino gentleman who presented with stable plaque psoriasis. He also had palmoplantar psoriasis and nail involvement, and he was quite fed up. He had been treated with various medications, and with methotrexate his LFT started going up, and he did not improve with the other medications including phototherapy. A decision to start him on biologic was made, and when I presented his case to the insurance, a basic insurance for that matter, I was surprised that they agreed straight away. Only thing is, after the loading dose, they backed out. They said we can't support this patient any longer. Luckily, patient support groups were available, systems were available, and he went into one of those systems and he continued the medication. The loading and the post-treatment, the significant improvement in the palms, significant improvement in the nails, and the feet. The third case was a middle-aged gentleman who was quite typical in the sense he had a stable plaque psoriasis of very serious level, and when he was referred to me by a general practitioner, he had a near erythroderma. He was shivering, and I had to put him on high protein diet and explain to him about poikilothermia and all that. Of course, he had features of stable plaque psoriasis. There was no doubt about the diagnosis. He had already had 2 stents after an angioplasty, and he was on medication. After evaluation, I did start him on secukinumab, and let me tell you, even within 2 doses, he showed a tremendous improvement. And by the time I reached the loading dose, it was nearly clear. An illustration of a patient with the comorbidities of psoriasis and the complications, and how well and how fast it improved with secukinumab. I do have challenging cases. To discuss one case, I have an obese youngster who has a BMI of 42, and he had been having psoriasis almost from childhood, and I did start him on secukinumab. He was not very compliant. He actually completed the loading dose with a significant PASI 50 improvement compared to baseline, but not PASI 75 or 90 like my other patients. Then he disappeared from UAE and went back to India and came back after a short gap. And there was a 3-month break before he restarted the medication. And I had a phase when I felt that maybe he is not a responder, and I was even considering either changing the biologic or adding a new medication. But luckily, over a 2 or 3 month period, he stabilized again. So let us come to certain definitions. See, the psoriasis experts of the world have been having Delphi conferences, and right from the days of alifacept and ifalizumab, definitions of how do you say a patient has responded. What do you mean by primary failure? What do you mean by secondary failure? What would you call as a good responder? All these things have been talked about and thrashed in the conferences. And the consensus is that any PASI improvement of below 50% of baseline is an inadequate response, which means either we have to change the medication, increase the dose, or reduce the dose interval, or consider combination or adding another medicine, or change the drug. Of course, a PASI 50 to 75 improvement compared to baseline throws up a challenge. Is he a responder or not? Here the DLQI kicks in, and if the DLQI is less than 5, it's an acceptable response. If it is more than 5, of course, he goes into the non-responder class. A PASI of 75 and above, of course, with a DLQI of less than 5, is considered adequate. What's a primary failure and what's a secondary failure? A primary failure is a failure in which a patient does not achieve a PASI of more than 50 compared to baseline right away, right from the beginning. A secondary failure is a person who is on the medication and then falls down. A primary failure may mean that we may be dealing with a molecule which is not going to work in this patient, and we may have to consider a totally different molecule. Whereas in a secondary failure, we may have to either increase the dose, reduce the duration, and other strategies depending on the molecule. What is rebound? Increased by 125% of the baseline PASI. Let me not waste time. Interleukin 17 group of cytokines have 6 isoforms in the 17A, B, C, D, E, and F. 17A and F are probably the most significant in the pathogenesis of psoriasis. Of course, secukinumab and ixekizumab target 17A, the soluble form, whereas brodalumab targets the receptor. Brodalumab is not available here. Of course, 17A is increased in the skin, in the joints, in the nails, and in the scalp. And they can be demonstrated to be increased in these sites, and targeting them is central to the clearance and pathogenesis of psoriasis and the interruption in the pathways. Of course, the pathway does involve other agents, and so many biologics are available to us currently, which is a blessing. Of course, this is a classical pathogenic loop that is demonstrated here. We all know the genotype. The Human Genome Project, which happened in the 1990s, in fact, the Indian Institute of Science, Bangalore in India, was a pioneer in doing this. I had even watched it. My brother-in-law is a physics professor there, and the physics people were people who were involved in this in a big way. So the Human Genome Project and the Nobel Prize winning thing, that is the development of the monoclonal antibodies in 1974, I believe, were turning points. The genotype, the triggers which stimulate keratinocytes to release pro-inflammatory molecules, the TNF, the initiation of the innate system and the adaptive system. The importance of interleukin 17, which are seen not only in the innate system but also in the adaptive system, and the blockage of the same, giving a comprehensive treatment of both the innate and adaptive immune inflammatory pathways in psoriasis is well illustrated here. Dedicated studies and trials of not only stable plaque psoriasis but also psoriasis of the nails, palmoplantar psoriasis, the scalp, and various domains and hard to treat areas of psoriasis have been run through in secukinumab trials. This is one of the important trials, the aeration and fixture trials, demonstrating superiority of secukinumab compared to the placebo and etanercept. A PASI 90 reading at week 12. You can see a clearly statistically significant improvement as compared to the placebo and to etanercept 2. Non-responder imputation and many things are being talked about of late, and I do believe they seem to be post-hoc analysis, and this is a response in the CLEAR trial demonstrating superiority of secukinumab versus ustekinumab, a PASI 90 response at week 16. You can see the significant difference, and of course superiority of secukinumab versus ustekinumab in a PASI 100 response on week 16, again demonstrating a clear-cut superiority. Of course, secukinumab has been run through in trials in the CLEAR trial with people who have had previous systemic therapy, people with no previous systemic therapy, I'm not just talking about the biologics, any kind of systemic therapy, and with previous biologics and also people who have been biologically named, showing the clear superiority of secukinumab in the management of psoriasis. Of course, it is licensed as a first-line agent in the treatment of adult moderate to severe psoriasis. Of course, it is also licensed in psoriatic arthritis in adults and I believe in ankylosing spondylitis too. Secukinumab showed greater improvement in all the symptom scores of improvement in psoriasis, not just the PASI, the pain, the itching, the scaling, and withdrawal of secukinumab. What happens? We are talking about real life situations. People are floaters in Dubai. They come, they stay 6 months, they suddenly disappear, they lose their job, they come back, there are breaks in treatment. So what happens if a patient on psoriasis who is well controlled or has shown a good response suddenly stops secukinumab? As we all know, the half-life of secukinumab is around 27 to 28 days, and 5 times of that, approximately let us say 20 weeks, is the time it takes for it to be washed out from the system. There is a possibility that a person will relapse after this time. I would like to say that so there's a lot of talk about what happens after medicine is withdrawn, and even the discussion has reached a stage where we are talking about persistent responders who might continue to respond even after medication is stopped, and this is one of the important points being discussed in the Delphi conclave on with the especially newer medications. PASI response after relapse on placebo. So again, see, once a patient relapses, the interesting thing about secukinumab being a UMAB, being a human monoclonal antibody, is that the patient regains response almost as good as the primary treatment, even after a relapse. And this is the PASI 75, 90 and 100 in the reinduction phase, where the patient was giving a loading treatment followed by the standard advised treatment. Secukinumab has been there for a long time now, more than 5 years data is available, and it clearly demonstrates maintenance of PASI 100, 90, 50 through 5 years, and sustainability of treatment is clearly demonstrated, and the quality of life, not just the PASI, the DLQI, and the sustainability of a good improvement in DLQI. Secukinumab has been studied, as I said, in dedicated indications like nail psoriasis, palmoplantar psoriasis, scalp psoriasis. This is a study on the nail, and it shows the clear-cut improvement in the NAPSI score. Approximately 60% of patients on secukinumab have clear or almost clear scalp psoriasis by week 24, and it is maintainable. I have had an experience which is similar to the literature. Of course, palmoplantar psoriasis and sustainability of palmoplantar psoriasis improvement over a period of 2.5 years. The results of the arthritis studies. Commenting on arthritis, we as dermatologists are not really the best persons to take care of the arthritis component of psoriasis. It's very important and wise to have a test score with us and a CASPAR to identify the patients and to pick up patients on with psoriasis who on an average within 6 years might end up getting arthritis. And it's very important for us to collaborate with the rheumatologist, the differential diagnosis, assessment, the functional disability indices, the calculation of the improvement in joint, the ACR 50, ACR 20, ACR 70. These are not tasks which we are familiar with, and we should not be entering their territory. And my own experience is that I have had a good collaboration with Dr. Humaira also, and when any patient has an arthritis, have no hesitation in collaborating with our rheumatology colleagues. A sustained ACR 50 and ACR 20 response has been demonstrated with secukinumab. The safety and tolerability profile, see, already my task has been made simple with Dr. Fatima, who gave a beautiful talk on ixekizumab. The IL-17s are highly targeted molecules, and even though they are important in mucosal defense, and we do have a condition where there's a congenital deficiency of IL-17, where patients manifest with chronic mucocutaneous candidiasis. In practice, let me tell you that I have a large number of patients in both the types of IL-17s, and almost none of them had any significant candidiasis. Injection site reactions, minor upper respiratory infections, and one patient had a herpes zoster which was possibly not related to the medication. These were what I actually came across. So, the common side effects. Of course, the side effects over many programs, the favorability, safety and tolerability profile through 5 years, which was comparable to etanercept, ustekinumab, placebo, long-term safety over 5 years, most common side effects being nasopharyngitis, headache and upper respiratory infections. Injection site reactions were very, very low. Immunogenicity with this UMAB is extremely low, and in fact, on retreatment, most of the patients can achieve the same results that they had given with the, comparable to the first treatment. I think with that, I'm done. Thank you.